Maybe. Thank you for attending this morning's session. My name's Naomi Morrick and my co-chair this morning is Kirsten Rance. Our session for this afternoon on rural and remote intensive care. Our first speaker is Paul Secombe. So I'll invite Dr. Paul Secombe to come up. Paul's an intensive care consultant at the Alice Springs Hospital, which is arguably the most remote intensive care in the country. In addition, he's a lecturer with the School of Medicine, Flinders University, and an adjunct lecturer in epidemiology and preventative medicine at Monash University. He has interests in nutrition, in the intensive care, particularly for the obese critically ill patient, Indigenous health outcomes following critical illness, and junior medical education, for which last year he received the NT Clinical Educator of the Year award. Thank you, Paul.
Good morning. Thank you. Thanks for that generous introduction, Naomi. Thanks also to the organising committee for asking me to come down and speak. And the remit that I was given was to try and talk about Indigenous critical care, whatever Indigenous critical care is. And for those of you who are fortunate enough to sit on Jane Thomas's previous talk, hopefully what I'll do is just sort of add to that a little bit more and perhaps put some numbers around it from a national point of view. So it's going to segue really quite nicely, I think. Before I go any further, I would like to acknowledge the past, present and future custodians of the land on which we're meeting, the Kaurna people. They've had a long and enduring link to this country that they call Tintanya, and it is truly a privilege and an honour to be standing on their country sharing stories. I have some disclosures, perhaps not traditional disclosures, but I think it's important to perhaps state somewhat self-obviously that I'm neither Aboriginal nor Torres Strait Islander. I can have no real understanding of what it's like to have continuous possession of a land for 60,000 years and then be dispossessed in the last 250. I don't think, however, that prevents me from trying to tell the story of Indigenous interaction with critical care services across Australia. I'm going to be talking a lot about big data. We're going to be using the adult patient database. The problem with using big data is also somewhat obviously that it actually hides millions of untold stories, and it's that richness of untold story that we can't try and encapsulate in this 20-minute presentation. I'm also going to be using the term Indigenous throughout the talk, and I may even use it interchangeably with Aboriginal and Torres Strait Islander. We need to be aware that we're talking about Australian data here, with apologies to our New Zealand colleagues. The Maori story is a separate one that needs to be told separately. But as a binational database, Indigenous is the term that's used in that database, and it's important to acknowledge that as Australian data, we'll be talking about Aboriginal and Torres Strait Islander people. I'm going to make terrible gross generalisations. There is a richness of Indigenous culture across the country that's reflected in the language map that you see up there. Again, in talking about big data, a lot of that richness is lost. Finally, it's going to be a very cursory overview. There's not a lot you can cover in 20 minutes. Before we go forward, though, and talk about critical care, a lot of this will be revision for you. I hope it will be revision, but it's important to understand the background demographics of where Indigenous people are coming from. So the 2016 census, 650,000 people identified as Aboriginal or Torres Strait Islander. It's about 2.8% of the population. Now, I need you to take that figure of 2.8 and pop it in the back of your head because it's an important figure that we'll refer to later on. They differ, the Indigenous demographics differ in some really important ways from the non-Indigenous. What you're seeing there is a distribution of ages. So not only is the median age of Indigenous people substantially younger than the non-Indigenous, 23 years compared to 38, but the distribution of ages is very different. You can see for the non-Indigenous, represented in the red bars, is that big bulge through the middle years. The really productive years from a career, economic and family raising perspective. And following on from a comment that Jane made in the previous talk about the importance of other family members contributing to the raising of children, you can see in that loss of those middle years, which are important for the extended family, and that loss is possibly due to excess mortality, that the Indigenous population is really suffering there. Where do they live? So there's 650,000 Indigenous people spread across the country. New South Wales is the most populous state, so it makes sense for most of the Indigenous people to live in New South Wales. So about a third of them call New South Wales home. What's more interesting, though, is when you look at it from a state-based proportion. So this is the same figures, but as a proportion of each state's population, you can see everything comes back apart from the Northern Territory. So our population, 26% of the Northern Territory population identifies as Aboriginal or Torres Strait Islander. The remaining jurisdictions drop back into the low single digits. In terms of where within each state Indigenous people are distributed, there is a disproportionate number of Indigenous patients in outer regional, remote and very remote compared to the non-Indigenous. And this is important from a health gap point of view. Voss and colleagues a few years ago compared remote and non-remote groups. And this is remote and non-remote, not Indigenous versus non-Indigenous. However, note that the Indigenous will be overrepresented in the remote categories. So although 26% of the population lives in remote areas, the burden of chronic disease, and I highlight four disease processes there in particular, is disproportionately borne by people in remote areas of Australia. Randall and colleagues using New South Wales hospital separation data published this earlier this year. The panel you see on the left is the non-Indigenous, the panel you see on the right is Indigenous. And what they did was relatively simple. They looked at the hospital separation data and simply counted the number of comorbid disease states that patients had at hospital discharge. The red is no comorbid disease, extending through to the yellow, which is 8. So not only do the Indigenous patients have more comorbid disease, it occurs at a much younger age. I've been sitting in there listening to Tim Walsh talk about comorbid disease and its impact on post-ICU care, wondering what that means for the Indigenous population that come through our ICU, given they carry a much higher burden of disease. And I still haven't got my head around it, but I think that's something that we can look at in the future. Again, another important figure, so that if you do the maths, there's a 2.6-fold increase in the number of comorbid disease states, and they're occurring at a younger age. That obviously translates into hospitalisations. This is Australian Institute of Health and Welfare data. The orange line is the non-Indigenous, blue Indigenous, and it simply plots hospital separations across the last 10 years up until 2015. You can see the orange line has been pretty steady at about 300 per 1,000 head of population. The blue line is increasing, and that gap is widening such that now the rate of Indigenous hospital admission is 1.25 to 1.3 higher than the non-Indigenous. And again, that's another figure I need you to pop in the back of your head. So 2.8% of the population, hospitalisation rate that's about 1.25 to 1.3 times higher than the non-Indigenous. The Australian Institute of Health and Welfare are also interested in potentially avoidable hospital admissions. A potentially avoidable hospital admission is a vaccine preventable one, often related to mental health and chronic disease burden. This one plots potentially avoidable hospital admissions by Indigenous status, this time the Indigenous in the light blue, the non-Indigenous in the dark blue. The vast majority of that is chronic disease burden. That puts the background epidemiology into some sort of perspective, I hope. What does that mean for critical care services and the sorts of patients that are coming in through ICU? And do a PubMed search, throws up 4 articles to describe a substantial proportion of our population. 3 of those are retrospective, 1 prospective, 2 from the Northern Territory, 1 from Queensland and 1 from WA, and all single centre studies. There are some themes that emerge from those studies. So not only are Indigenous people overrepresented in ICU admissions within these centres, but they tend to be younger, they've got a higher chronic disease burden and far more emergency than elective admissions. The diagnostic categories are predominated by sepsis, cardiac arrest and trauma. Despite that, and despite the higher comorbid disease burden, once mortality is corrected for chronic disease and illness acuity, the mortality, hospital mortality for Indigenous people versus non-Indigenous in these studies at least is the same. Does that play out on a national level? Fortuitously, we have the ANZIC's core APD to pose this question too. They've coded for Indigenous status since 2007 when it was introduced as a non-mandatory field. It was made mandatory in 2010. As a binational database, it defines Indigenous status as a patient who identifies as Indigenous to the country in which they were admitted. Now that has a flaw, clearly, because it means that Maori patients admitted to Australian ICUs will not count as Indigenous, and if we think Indigenous is important in outcome, it's a failing of the database that may need to be addressed down the track somewhere. We're going to look at just 2017 data. We need a contemporary picture of what's going on. If we look at 2017 data, it's about 160,000 admissions, and across nearly 150 intensive cares, which covers every jurisdiction in the country. Covers 90% of ICU admissions, and there's obviously some people we need to pull out of that. So patients that haven't been coded, the handful of paediatric patients that end up in adult ICUs, and to avoid double counting we need to take out the readmissions and the inter-hospital transfers. Taking out the inter-hospital transfers is a little problematic because you take out the ICU to which they presented, in which case you might dilute the illness severity scores, or do you take out the ICUs to which they were ultimately finished up with, in which case you might end up with some flawed mortality data. In this case, we've taken out the final ICU because I think it's the where they're coming from, and the illness severity is what we're really interested in. As you would expect from that background epidemiology that I've given you, 10 years younger. If you think Apache 3 is a marker of illness severity, then the illness severity is about the same. As most of you would know, though, the Apache 3 score has three subcomponents: an age component, an acute physiology component, and a chronic health component. 10 years younger, their age score is obviously going to be statistically, and I think clinically, significantly less, and the degree of acute physiological derangement as measured by those variables in the first 24 hours is substantially higher. Where are they being admitted? I think places where you would expect. Now, I'm going to spend a bit of time on that graph in the bottom right-hand corner because it's a little bit complex. What you're seeing there is ABS census data for each jurisdiction. That's the purple and the pale blue bars, and then the adult patient database data, which is the dark blue and the orange. So Indigenous and non-Indigenous and Indigenous each time. You can see for the vast majority of jurisdictions, just based on that, there's not a lot of difference between the non-Indigenous ABS data and the non-Indigenous APD data, with the exception of the Northern Territory, which is as you would expect. I want to focus on that bottom 30% though, because that's where we see a little bit more detail. That's just blown up, and I'm going to take out the non-Indigenous data. Once you do that, it becomes pretty obvious that in every jurisdiction, with the exception of Tasmania and Victoria, Indigenous patients are overrepresented. And they are more overrepresented in WA and the Northern Territory. That Northern Territory bar actually goes way off into the stratosphere there. It's about 75% of Northern Territory admissions. Tasmania surprises me. That's well down, and I'm not sure if that's a coding issue or something else is going on there. Queensland's the other one that surprises me a little bit because, as you would have seen from those previous slides, Queensland also has a high proportion of Indigenous population. So that there may well still be some coding issues going on in the APD that need to be looked at. That graph actually looks not dissimilar to this one from the Australian Institute of Health and Welfare, which looks at Indigenous and non-Indigenous age standardised hospital admissions in each jurisdiction. And again, I would expect, this is one of the things that makes me question the Queensland and Tasmania coding in particular, because the proportions there are much more like what you see at the state-based level rather than what we're seeing in the APD. But either way, you can see that Indigenous patients are still overrepresented. And remember that figure of 1.25 to 1.3, because that's about what you see in the hospitalisations. Across the country, Indigenous people are actually 1.9 times more likely to end up in ICU. Where are they being admitted from? So what's their home address? The APD contains postcode data, which allows us to code them into the 5 major categories, ranging from major city to very remote. And as you expect from the background epidemiological data, most of the Indigenous people are coming from very remote rather than from major cities. We can also look at it from which classification type of ICU are they coming into, and again, as you'd expect, mostly regional and rural. Where they're not going is into private ICUs, which again is probably a socioeconomic factor, which may also point to an access issue. When we're thinking about remoteness, we often also think about disadvantage. There are 2 major scales of disadvantage in use currently. One is the ARIA score, which is derived at the University of Adelaide, which basically measures how inaccessible the township or community is that the patient's coming from. They look at distance from a major population centre, the type of road and how long it takes to get in there. And in this case, the higher the score, the more remote. This is just a median score for each of those populations, and as you'd expect, Indigenous people are from far more inaccessible communities. The other major scale in use is the IRSD, which is the Index of Relative Socioeconomic Deprivation, which is an ABS score derived from things like median household income, how many cars per household, the education level of households, and overcrowding. In this case, the lower the number, the more disadvantaged the community the postcode is associated with. And you see there clearly a significant difference between Indigenous and non-Indigenous. Where do they come from? From immediately prior to intensive care? I think, as you would expect, and as you could sort of guess from that lack of admissions to private ICUs, most of them are coming from emergency, and they're not coming from the operating room or from recovery. Most of the proportion of patients needing an emergency versus elective admission is also disproportionate, favouring non-Indigenous, so Indigenous patients more likely to be admitted under emergency conditions. And for reasons that I can't understand, more likely to be mechanically ventilated. I don't know whether that's the physiological derangement. I don't know whether it's the emergency nature of the admission. I don't know whether it's related to the need for subsequent inter-hospital transfer. All of these things are questions that will need to be drilled down in the future. Again, also reflecting, I suspect, the more profound physiological derangement and the emergency admission is the Indigenous patients are spending fewer hours in hospital prior to making it into the ICU. Diagnostic categories, again, as most of you would know, APD uses a modified Apache 3J diagnostic codes, coded as operative and non-operative. So all I've done here is combine the operative and non-operative codes for some major diagnostic categories: cardiovascular, following cardiac surgery, respiratory, neurology, gastrointestinal sepsis and trauma. What's plotted there is Indigenous and non-Indigenous, the non-Indigenous in blue, Indigenous in orange. Plotted as an odds ratio against the non-Indigenous admission diagnosis of a cardiovascular disease. They're far more likely to come in for 4 common causes. So cardiovascular admission diagnosis, respiratory, sepsis and following trauma. And unfortunately, Fraser's actually presenting his trauma project next door as we speak. Who he's looked at Indigenous outcomes in trauma specifically, and it's some really interesting stuff that we published in the Medical Journal of Australia in November. Somewhat alarmingly also, if you look at the admissions post-arrest, so Indigenous patients have a 1.5-fold increase in admissions following cardiac arrest and nearly a 2-fold increase following respiratory arrest. Again, is that a physiological derangement that's driving that arrest? Is it a reflection of the cardiovascular disease that exists in a higher burden? Is it a measure of poorly managed chronic disease? Not sure. Again, Australian Institute of Health and Welfare data. Let's take out dialysis because that's an unavoidable admission. You'll see here, so this plots the rates of Indigenous and non-Indigenous. Again, sadly, the colours are mixed up. I apologise for that, but non-Indigenous in blue and Indigenous in blue, non-Indigenous in orange. And you'll see it's the same sorts of disease processes putting people into hospital as putting people into ICU, but again, more likely to be ICU. That's again 1.9 for ICU in general, which is not dissimilar to those 4 disease processes. Outcomes, once mortality is adjusted for illness severity, for chronic disease and a few other complicated things into a model, you can see that for the diagnostic categories of interest that we've looked at, there's actually no mortality difference. So people are coming into ICU sicker, younger, but the good news story for intensivists is I think that they are surviving their ICU stay. And it's not... It's a very similar story depending on remoteness. I'm going to try and summarise all of that. It's a lot of data, and I haven't done it justice in the time that we've had. But certainly we can say that Indigenous people are overrepresented in our critical care admissions. They're far more likely to come in for an emergency admission rather than an elective admission, which might reflect an access issue out in the community. Far more likely to come from areas of disadvantage and more likely to be ventilated. The reasons for which I'm not entirely clear, and there's another project moving forward. I think it also identifies some of the areas for our public health physicians and our policy makers. These are the areas where they are overrepresented in ICU admission. Some of those are actually, in fact, the vast majority of those are modifiable prior to ICU. And perhaps if we can modify some of those, we might make some inroads into that overrepresentation in critical care. Thank you. I think I've got time for questions.
Thank you, Paul. We have one speaker that hasn't attended, so you have a few extra minutes for questions. Has anyone got a question? We've got a mic. Start with Drew.
Hi, Drew Wing from Cancer Intensive Care. Do you think smoking is related to the increased rate of ventilation? Because
I don't know. I can't answer that question. I think smoking status in certainly the Aboriginals that we see is really difficult to get your head around, because quite often Aboriginal patients will smoke, but only when they have the funds available to do so. So it's not it's difficult to know how much they've smoked, and in fact we quite often don't even include it in our history taking in Alice Springs. It's also confounded by there's obviously tobacco smoke, there's a lot of marijuana in our bit of the world, but there's also campfires that they sit around and often in enclosed spaces. So it's difficult to tease all of those things out. I think it's certainly a possibility. We also see a lot more respiratory disease. There's a lot of bronchiectasis in our bits of the world, and similarly up in the top end. I haven't worked in far north Queensland, so I don't know, but I suspect the diseases that you see there are not dissimilar. So lots of diabetes, lots of bronchiectasis, lots of rheumatic heart disease. Short answer is I don't know.
Any other questions? No? Could you please join me in thanking Paul for his presentation?